Good afternoon, and welcome to another in the series of Lunch and Learn programs of the League of Women Voters of the Ann Arbor area. We are a nonpartisan political organization encouraging informed and active participation in government. We influence public policy through education and advocacy. While we are nonpartisan, we advocate for public policy positions that have been approved at the state or national level, or on local issues that our memberships has studied and approved. We do not ever support or oppose candidates. Today's Lunch and Learn topic, healthcare reform, improved healthcare for all, speaks to the National League's position on healthcare. That position is: the League of Women Voters of the United States believes that a basic level of quality healthcare at an affordable cost should be available to all U.S. residents. Other U.S. healthcare policy goals should include the equitable distribution of services, efficient and economical delivery of care, advancement of research and technology, and a reasonable total national expenditure level for healthcare. You'll find more information on that position in the League's Impact on Issues, and I'll post the connection for that in the chat box when I'm finished introducing our panel. Today's event is being recorded and streamed live on Facebook and will be available on the League's YouTube channel at a later date. We are fortunate to have as our panelists today three very savvy members of the Ann Arbor League's Advocacy Committee. There's Sue Smerick, PhD, RN. She's a professor emeritus from Eastern Michigan University. Sue has taught undergraduate and graduate nursing students in healthcare organization and community health nursing. She currently serves on the Ann Arbor League's board, and as a member of the League of Women Voters of Ann Arbor area, she's been a member of the Advocacy Committee and the League of Women Voter U.S. Healthcare Caucus. Kate Moore, PhD, RN, holds graduate degrees in nursing administration. Out-of-pocket healthcare costs were the focus of her funded research. Initially, she was a director of a Robert Wood Johnson Pew Charitable Trust grant to compare system healthcare costs and length of stay results between two nursing care delivery protocols. Kate taught leadership, management, and organizational systems to students in undergraduate and graduate nursing programs. Her volunteer work has included serving as a nurse in Louisiana after Hurricane Katrina. Jackie Wolfe, PhD. Jackie, in the 1980s, began reading about single-payer healthcare while directing a research project on the healthcare needs of lower-income Black and urban elderly for Case Western Reserve. In the 90s, she joined Massachusetts League and served on the state board, chairing that league's Amherst Healthcare Committee and participating in the league's U.S. Healthcare Caucus. From 2006 to 2016, she was co-chair of the MassCare, the Massachusetts Campaign for Single-Payer Healthcare, which advocates for a state single-payer plan as a model for the nation. Since moving to Michigan, Jackie has been involved with the League's membership and advocacy committees. We'll take questions at the end of the presentation. Please enter them in all caps into the chat box. We'll get to as many as we can and to answer any we can't get to by email to the entire group. If you're watching on Facebook, please email your questions to info@leagueofwomenvoter.lwvannarbor.org or place them in Facebook. And because I forgot to say it, I'm Joan Sampieri. I just assume you all know me. I'm the president. I'm pleased to be the president of the League of Women Voters of the Ann Arbor area. And now to our panelists. Jackie, I believe you'll start us off.
Yes, Thank you, and thank you to all. I see lots of friends on our program today, and it's great that you joined us. I want to begin by thanking Joan and Dee Deshawn for giving us this opportunity to talk about the League of Women Voters' strong healthcare reform position. Our Ann Arbor League Advocacy Committee has a healthcare reform subcommittee. In addition to the three of us who are presenting today, Sarah Fink and Virginia Ardis are members of the team. And if you would like to join us, please contact Carolyn Madden, the Advocacy Committee Chair. We'd love to have more help. We view this program, and could I have the next slide, please? Thank you. While it's coming up, I'll just let you know this program as the beginning of a conversation which we would like to continue as the national healthcare reform debate heats up. We would like to present this program to leagues all over the state and to other organizations, professional groups, civic groups, faith groups, even neighborhood groups. We would like your help in getting contact information and suggestions. There is so much to discuss on this important topic. Today, we will concentrate on three issues about the League's healthcare position. And the second topic will be the major factor affecting healthcare costs, and I will tackle that. And then Kate will go into detail about improved Medicare for all. So now let's begin. Sue, take it away.
Welcome to everyone, and thank you for being here. I'm going to talk, as Jackie said, about the League's position on healthcare, as well as characteristics of our current healthcare system. Next slide, please. The League of Women Voters has a position on healthcare since 1993 after completing a 2-year study process. And this position is found in the publication that Joan referenced, Impact on Issues. The position was updated in 2016 and includes mental health care. The position has always included a focus on the goals of the healthcare system that you see here: access, affordability, and quality of care for all Americans, while protecting patient family rights, as well as including strong cost control measures. With the League focus on diversity, equity, and inclusion, the healthcare position also has an emphasis on equitable distribution of services and delivery of care to eliminate health disparities. Service should not be determined by the ability to pay for service, but a set of criteria based on need and availability of treatments. Basic healthcare services should include disease prevention, health promotion, and education, primary care, including reproductive health, acute care, long-term care, and mental health parity. These services include prescribed medications. You can see that this list of covered services far exceeds our current healthcare insurance, or most current healthcare insurance. The League favors a national health insurance plan financed through general taxes in place of individual insurance premiums. Accompanying increased taxes, the League supports strong cost control reforms, and many of these reforms the League has identified. What have we done in the healthcare system about this position? The League of Women Voters has a history on healthcare lobbying and educating for healthcare policy solution, including testimony before Congress. The League also provides educational programs to inform members and citizens about healthcare issues, including this one. The Arizona State League has organized the healthcare toolkit that we'll talk about later, and organized the National Healthcare Caucus to develop educational information about improved Medicare for all, to provide programs at national meetings and advocate for improved Medicare for all. State and local leagues educate and advocate for healthcare reform as well. A current focus is on local resolutions supporting Medicare for all. Locally, these include the Ann Arbor City Council, Washtenaw County Board of Commissioners, Pittsfield Township, and work with Scioto Township. This brief summary highlights how the League of Women Voters has a long history of advocating for healthcare reform, including Medicare for all. Could we go back to the previous slide on access? There we go. How are we doing on these goals in our healthcare system? While 30 million people were without healthcare insurance before COVID-19, we can only imagine how many more people are without insurance now due to illness, loss of employment, and caregiving needs. Many families may still have one member who may have insurance, while others, especially low-income workers, either never had insurance or lost it with their jobs. Changes have been acute for women who have left the workforce to care for family members who are ill and to assist children who are now home, expected to do online learning. People with health insurance they like may wonder, why is this my problem? People without health insurance typically use emergency rooms for their primary care, which is associated with the highest cost and lowest continuity of care. In addition to those without insurance, 41 million people are estimated to be underinsured, which means they are less able to handle the cost of care. And racial and economic inequities remain. People of color and low-income workers are more likely to be underinsured or uninsured. People of color account for half of the uninsured. They pay a higher percent of their income on healthcare. One example of inequity is that Black mothers are twice as likely to lack prenatal care that comes from a lack of access. What are some examples of the impact of this poor access to health insurance? Our daughter has insurance through her work that is a health savings account. With a recent attack of her chronic back pain, she quickly used up her allocated savings and is now in debt and was not able to complete the recommended plan of care. Our grandson, Taryn, who is 22 and on the same plan, then had the inability to have a health care problem evaluated. Postponing and undertreating problems that limit positive healthcare outcomes are issues with being uninsured or underinsured. Although these examples are not incredibly serious, they illustrate the problem when healthcare issues are not well addressed. A friend of mine, who by the way sells health insurance, elected to purchase a catastrophic health plan for his healthy family. His son broke his leg in sports and his wife had an extended injury that left them paying more than $15,000 in healthcare costs for that year out of pocket. They took a gamble to save money. While this family was able to meet their healthcare expenses, many others are not. The next slide, please, for affordability. The high cost of healthcare strains budgets of the government at the national, state, and local levels, as well as families, businesses, and households. It's estimated the average cost of employee health coverage for a family was reported to be over $21,000 per year. These annual premiums have risen at 4%, which is much higher than inflation. This slide also shows that 25% of Americans just struggle to pay for their medical bills, and 42% of cancer patients lose their assets within a period of 2 years. What are some of the examples of lack of affordability? Inequities occur when different patients pay different prices. The Wall Street Journal in February of this year ran an article, "How much does a cesarean section cost?" The answer was from $6,000 to $60,000. So the type of insurance or lack of it affects the cost of the same service to different individuals. Back to our daughter, Beth. The only insurance plan she could afford was a health savings account that includes contributions from herself and her employer with a catastrophic level of care. With the chronic back pain, the savings account was depleted, causing her to have, as I said before, less than recommended care. But this plan was the only one she could afford that included her son, Taryn. She was offered an individual plan, which she could afford, or a family health care plan that cost 3 times as much for her small family of 2. These cost burdens lead to increases in bankruptcies as well. It's estimated that 62% of personal bankruptcies result from medical bills. Most of these people are middle-class people who did have some level of health insurance. A friend of mine who has been a long-time employee at a local grocery store chain is a union member and has health insurance. As a result of an injury, he required 5 surgeries to save his foot, a long rehabilitation, and was off work for several months. His medical bills that were not covered by insurance amounted to over $50,000, and an amount of money he could not pay back. This resulted in a bankruptcy. The health care he received did save that foot and did allow him to return to work eventually. However, the bankruptcy process took over 2 years and more stress than anyone could ever imagine. Other individuals and families end up resulting to GoFundMe campaigns. So affordability poses a threat to many, many families. Next slide, please. Is quality patient-centered healthcare a problem? How we evaluate quality often starts with what is our choice of healthcare providers? Can we pick the provider we choose? Many plans, especially managed healthcare plans, limit the choice of healthcare providers. The ability of insurance companies to oversee and intervene in physician treatment plans is also a concern. They sometimes even limit the choice of treatment or deny coverage. This has led to a whole industry of billing personnel who manage what diagnosis is recorded and other aspects of the claim with the hope that it will end up being reimbursed. This also leads to insurance company practice of trying to retain healthier clients and drop less healthy clients. This is often called cherry picking or lemon dropping. Other health examples of outcomes are health outcomes are a measure of quality. What do we get for all the money we spend? The United States ranks poorly as a nation compared to other developed countries, spending much more money than those countries. There are also wide geographic, economic, and racial disparities as well. Life expectancy among the developed nations, the United States life expectancy is 78.6 years. 28th of the 33 developed countries. During this past year, it's been reported that life expectancy in the United States has dropped a whole year. So in this difficult time, you can see the big impact. In the United States, maternal mortality is 19 per 100,000 live births, which also ranks low among other developed countries. But the inequity comes when we find that Black mothers experience 3 times the mortality of white mothers here in Michigan. As well, infant mortality, which is the number of infants who are born live who die within the first year of life, is 5.9, which again is high compared to other countries. But here in Michigan, infant mortality is 3 times higher for Black infants than white infants. This information shows us that our current healthcare system has deficits in access, as well as affordability, and as well as quality. Now to Jackie.
Jackie, you're muted.
Pardon me. Thank you so much, Sue. Who is the culprit? Who is the culprit? What is the major obstacle to ensure all Americans have access to affordable quality health care? For those who seriously study this issue, the answer time and again is the private health insurance industry. Let's look at why. First is private health insurance. Private health insurance can be a sticky term. It is usually defined as any health insurance coverage offered by a private entity that is not the state or the federal government. Insurance brokers and companies both fall into this category. There are approximately 900 private health insurance companies operating in the United States. In addition, companies and organizations have self-insurance plans, and those are also considered private health insurance. And if you start adding up those, you're getting into the thousands. That sounds like a whole lot of market competition, which some would say keeps down the cost of the insurance policies. Well, interestingly, 5 of the major health insurance companies, that is Anthem, Centene, United Healthcare, and Healthcare Services Corporation, for 44% of the covered patients. Next slide, please. On this screen, 6 major reasons why the multitude of private health insurance companies in the United States drive up costs. Let's go down the line. Eligibility. Does your plan include the treatment prescribed by your healthcare provider? Prior approvals for treatments. Your healthcare provider, in most or many instances, needs to get private approval from the insurance company. Claims denied. This is an all too common problem for both the healthcare provider and the patients. Billing and collecting payments. We know that this is multiplied by the multiplicity of the health insurance companies. $1 million salaries of executives. We'll return to this item in a moment. And profit, yes, profit for shareholders. Next slide, please. What is the impact on hospitals, physicians, and healthcare providers? The burden on doctors and doctors' offices of processing all of this information for the multitude of insurance companies is tremendous. As this slide says, doctors spend as much as 20% of total revenue for getting approvals, billing, challenging denials, collecting payments, et cetera, et cetera. In addition, in the United States, unlike other developed countries, for every 10 physicians in primary care, we need 7 additional office people to collect payments. Let me digress for just a moment. Some doctors are getting so fed up with this that they are refusing to accept insurance company payments. This approach was highlighted in a February 2021 article in the Ann Arbor Observer. They refer to the process or the procedure as a direct primary care. Patients who enroll with a direct primary care doctor pay flat fee, say $30 to $90 a month, depending upon your age. Again, the doctors don't accept any insurance. The doctors say that they are much happier, even though they make much less money. But there's a catch here. This covers primary care only. The patients need to pick up major medical insurance policies or some other insurance in order to cover their other hospital and healthcare needs, medical devices, drugs, etc. Direct primary care is not an answer to what ails the United States healthcare problem. Next slide, please. Let's look at this issue of costs of the health insurance companies in another way. We just talked about the fact that for the doctors, they spend as much as 20% of their total revenue on taking care of the paperwork of the private health insurance companies. Another issue to ask is how much of our premium dollars do the private insurers use in taking care of our health care? Well, it turns out only 8%. Or in other words, as the slide says, private health insurance companies spend as much as 20% of our healthcare dollar on overhead. Overhead? What's overhead in the private health insurance company market? Well, it's marketing, it's advertising, it's maintaining a sales force to sell policies. How about naming rights on sports stadiums? High executive salaries and profit. Profit for shareholders in private insurance companies. For example, if you want to check out the stock price of Aetna, their New York Stock Exchange symbol is AET. Our premium dollars goes into these expenses indirectly or directly. Now, by Medicare overhead is 2%, a tenth of what the private health insurance companies spend, 2%. Next slide, please. To drive this point home, this slide shows the total compensation in 2019 for 3 top health insurance executives. For each one, I'm going to tell you the number of insurers under their policies. Mr. Bartoloni, CEO of Aetna, had compensation of over $58 million in 2019, and the company covered $39 million. Mr. Wickman, CEO of Health, had healthcare total compensation of $83 million in 2019, and the insurance company covered $7.3 million. Mr. Lope, CEO of Blue Cross Blue Shield Michigan, had total compensation of $19 million, and this company covered $6.1 million. What's the comparison with Medicare and Medicaid? First, Medicare and Medicaid, as of 2019, covered 60 million people. We can well imagine that number has increased dramatically since COVID, but 60 million. And what about the compensation? The administrator of Medicare and Medicaid is appointed by the president and confirmed by the Senate and makes a salary of less than $200,000 a year. Under the administrator are 2 directors, one of Medicare and one of Medicaid. Each of these directors makes a salary annually in the range of $160,000 to $180,000. My point is twofold. The primary health insurance industry is a burden for providers and patients alike. The high overhead, including high executive salaries, profit, advertising, everything that we've mentioned, does not contribute to the quality of our healthcare. And the second point, there is no question that the directors of Medicare and Medicaid have responsibilities for programs that cover far more Americans, and yet their total compensation is a fraction of what goes into the pockets of the private health insurance executives. The overhead of Medicare is 1/10 that of the private health insurance companies. So let's talk about improved Medicare for all. Kate, take it away. Next slide, please.
Thank you, Sue, and thank you, Jackie. I'm going to talk about the elements of an improved Medicare for All program and how this program is compatible with meeting the League's goals of access, affordability, and patient-centered care. One of the answers to strengthen United States healthcare is streamlined insurance coverage. Medicare for All provides coverage for all aspects of healthcare. Whatever your healthcare needs are, an improved Medicare for All program will pay for them. Healthcare must be medically necessary. One presumes that the optional cosmetic surgery, for example, would not be covered by this fund. Every one of us is covered throughout our lifespan. There is no need to opt in or out. We won't spend time each year analyzing, weighing decisions, or guessing about which plan might offer us the best protection. It will not be necessary to seek and pay for additional coverage to fill the inevitable omissions of our basic plans. With streamlined coverage, there is no need for separate plans to cover hospitalizations, to cover outpatient treatment, or for medication or dental insurance. By the same token, the staff and physicians and healthcare providers' offices will not spend time and money to determine what may or may not be covered for every patient that requests care. Currently, policies change each year, and the time-consuming and expensive learning curve begins again for everyone. The second point is that each of us will be able to choose the healthcare providers we prefer, including physicians, hospitals, therapists, rehab centers, and any other healthcare providers whose services we want or need. If we unexpectedly need treatment in another location, we would not be charged out-of-network fees. Or if we have a preferred provider in another location, we can receive care from them, also without the concern of additional fees. Third, our healthcare bills, all of them are paid from one public fund. Next slide, please. With improved Medicare for all, the goal of access is met. Everyone has health insurance from birth to death. Coverage includes preventive care, lab tests, procedures, treatments, therapies, medications, equipment, and follow-up care. There would be no denial of treatment because of insurance constraints, reduction in work hours or unemployment, nor because of age, relocation, a change in marital status, or because of inability to pay. This ensures that no one would be barred from the care they need, or that costs would be shifted to other patients. Next slide, please. With improved Medicare for all, the goal of affordability is met. Point one, everyone pays into one fund and receives coverage from that fund. There are no deductibles, no co-pays, no out-of-network charges, regardless of the location of the service or provider. For example, even when we travel anywhere within the US, there are no additional or unexpected charges should we need health care. With Medicare for all, coverage continues seamlessly. There are no delayed or surprise charges. Third, payments to the healthcare fund are based on income level and ability to pay. Private insurance costs are eliminated. Payments to the National General Fund provide all needed health care each and every year. Global budgeting. Global budgeting refers to the practice of paying hospitals and healthcare providers a preset fixed amount for the total number of services they provide during a given period of time. And I'll talk about this a little bit more later. Next slide, please. With improved Medicare for all, we would meet the goal of quality patient-centered care because, first of all, each individual chooses a preferred healthcare provider. Second, there would be a distinct focus on preventive care, since there would be no charge for visits to receive preventive care. People are more likely to use this feature of healthcare. Studies have shown that charging even a small fee for preventive care deters us from making an appointment for preventive care. Third, another element of patient-centered care is the coordination of care among providers. It will be much easier to effect referrals since there will be no delay in waiting for approvals, acceptance, or authorizations. Fourth, hospitals and outpatient staff will not have to spend costly time, which affects both the patient's health and the system, dealing with the denials and contradictions of multiple insurances when a patient needs procedures, treatment, or referrals. Next slide, please. Financing. The United States spends an enormous amount on healthcare, nearly $4 trillion a year on healthcare. That's the number 4 followed by 12 zeros, tidily separated by commas. Despite the amount this country spends, many of our healthcare outcomes are worse than other countries. You've heard Susan talk about this. Consistently, vulnerable populations do not get the care they need. Some of the vulnerabilities include socioeconomic status, racial differences, age differences, including the young as well as older adults, the unemployed and the underemployed. 60% or 2.4 trillion of that 4 trillion is covered by government programs now, including Medicare and Medicaid. The remaining 1.6 trillion is not new or additional spending. We now spend that amount on private insurance premiums, deductibles, co-insurance, and working out who pays what, which care is not covered, and what additional coverage we are likely to need. As I said, oftentimes it's a guessing game. Patients have co-payments and other out-of-pocket costs. For example, transportation, parking, child and elder care, equipment, supplies, special nutritional regimens, expensive medications. Patients would have the funds to use for these, if necessary, if they were not paying for premiums, co-pays, and other insurances. Next slide, please. Savings. Okay, where would the savings come from? With improved Medicare for all, the savings would come from administrative efficiencies. Our healthcare system would not be paying clerical staff to determine allowances for each type of policy, to prepare multiple rounds of billing, and for follow-up billing. As mentioned, this currently starts anew each year with every round of reconfigured policies. Savings come from cost containment. Drug and equipment companies will not be able to charge huge amounts for meds or equipment, since one buyer, an improved Medicare for All program, will be managing the negotiations and purchases for all patients. Drug and medical equipment companies will compete with each other to do business with a centrally managed healthcare plan. Pricing power, one purchaser, that is Medicare, will be able to determine reasonable costs for meds and other items. Global budgeting, rather than being paid on a case-by-case basis, hospitals would receive one sum and decide how to allocate funds for that particular time period. These budgets are reviewed and adjusted as actual costs are assessed. This approach allows better planning for administrators as well as for healthcare providers. With improved Medicare for all, the United States would save an estimated $2 to $5 trillion over a decade. The strategy of an improved Medicare for All program means that every one of us is assured lifelong care without becoming impoverished, regardless of acute, critical, chronic, or long-term healthcare needs. People will pay the same or less for more healthcare benefits. Next slide, please. Jackie will now share a healthcare toolkit with you.
Thank you so much. And we are wrapping up here. First, I want to say that there is a network of league members from all over the nation who are working on health reform advocacy. Delighted to see some of those folks on our program today. Hi, Barbara, hi, Paul, and various others. The Arizona League features a healthcare toolkit for league members, as just mentioned, and the website address is on the screen for those of you who would like to follow up with that. I will also note that there are leagues in several of the states that are working on single payer plans. New York is the outstanding example. California has been fighting for this for decades. And again, the leagues are involved in that fight. Massachusetts, for sure. Colorado, Vermont, these are just examples. And finally, there are good websites with good resources for all those who are on the program today who would like to follow up. These are three of my favorite: Michigan for single payer healthcare, Healthcare Now, and NHP, Physicians for a National Health Program. Next slide, please. So with that, we hope that you've enjoyed this program. I know we've given you a lot of information. We look forward to your questions. Thank you, thank you, thank you.
There are several questions in the chat box. Let's see, and there are several comments. We'll take questions. I know a number of physicians who no longer accept Medicare or Medicaid patients because the reimbursement rate is so low. How would reimbursement rates be set in improved Medicare for all?
That's a very good question. And again, when we think about an issue like the costs of Medicare and Medicaid or the reimbursement rates now in the climate that we have, please remember what we've talked about, that the private health insurance companies are indeed a major factor in siphoning off major dollars that support health care. The doctors who are choosing not to take Medicare and Medicaid now under an improved care for situation, the pricing would be boards that would include healthcare providers, and that the reimbursement rate would be a respectful amount given the cost of services. This, I must mention to you, is not a new model, okay? The major Western industrialized countries of the world, most of them use single payer. And we find, in fact, the doctors in those programs and in those nations are well compensated, and they live a nice lifestyle. We do not have a tremendous exodus. We do not have a tremendous importation of doctors from fleeing other countries to come to the United States for a better quality of life. Sue, want to add? Please, go ahead.
You're muted, Sue.
I was trying not to make noise while we were talking. I think you also have to include what are the savings to physicians' practices in this environment. The constant fussing with billing and rejection and so on. There is the cost savings, and you're getting closer to the physicians being able to concentrate on their healthcare practice instead of their healthcare business.
Thanks. Someone else says, I know persons in England and Greece where healthcare is socialized both come to the United States when possible for surgeries and other care. They cite poor care in their countries. How would Medicare for All ensure a continued high level of care in the US?
It is an interesting question, and anecdotal evidence is certainly important for people. I know that Sue is going to add some about the issue, the question, sometimes a related point about care or waiting care. One of the first things, and I hate to throw in is there used to be a joke that would said, what's the bad thing about turning 65? And the answer, turning 65. What's the good thing about turning 65? And the answer is, you're on Medicare. And the point of that is that for the millions upon millions of us, and I include myself, who have Medicare, I think the evidence is clear. We do get good care. Here in Michigan, at least the care that I have been offered through the healthcare provider with Medicare has been nothing but quality care. So yes, there are concerns and questions by other people in other countries for a whole variety of particular reasons. But the question of, do we have evidence that Medicare provides poor or uncare care? The answer is no. Sue, do you want to jump in?
I think there are a couple of things to answer. One is we are creating a system with Medicare for All that everyone has access to the quality care that we have. Are there areas in which demand may be higher? I'm in that over 65 group, and when we have needs, we sometimes have to wait a little while to get those met. But the quality of care comes from being able to have access, you're talking to a public health nurse here, to prevention as well as focusing on the high level treatments and managing healthcare in a reasonable quality way. Whether we're talking about diabetics who can't get access to insulin, and so they end up needing very high level care. This system provides the best way for people to have ongoing care for their healthcare needs.
Thanks, Sue. There's a two-sided question from two people. One was concerned about how we would deal with the number of potentially displaced insurance company workers. And one wondered how the number of potentially displaced insurance company workers compares with people who become impoverished or unemployed due to a healthcare crisis. So they're asking from a two-pronged approach. If we do Medicare for All, and people who are currently administrative help in private health insurance companies, what happens to them? And if our current system is retained, what happens to people who become impoverished, unemployed, or bankrupt because of our current system? So can you sort of pull those two together?
I've never heard those two matched like that, and you might have to get a follow-up question. But the first is a straightforward answer. So there is the bill that is the closest legislative match and to what we're talking about, and what the League's position directs us to is the Medicare Act for All of 2021, recently introduced to the Congress by Representative Jayapal. What is, and here's a little digression, but I will get to your point. What is exciting about that is that there are 114 co-sponsors. Now, that's the largest number of congressional people who have signed on to this type of legislation, Medicare for All. In addition, what's even more striking is that 14 are the chairs of the House committees, including the chair of the House Committee on Energy. I mean, we're getting attention, we're getting serious consideration. This is moving. Now, to get back to your question, the connection is the legislation talks about a 5-year transition period where all those people, particularly insurance agents and whatnot, who are deemed.
I think perhaps Jackie is frozen here for a minute, but what she was referring to is that there is in this current bill money for transition for workers. The goal here, though, when you think about it, when you have people employed in healthcare, is to have the larger number of people employed in delivering care rather than fussing with the administration. But there is in the new bill money in the transition time to help people regroup and transition.
Does that answer that second part, Joan? I'm not sure.
I don't know the numbers to
That'd be something interesting to look at.
think about.
How
I'm
many?
not going to guess.
I'm sorry?
I'm not going to guess or sort of go beyond
No.
what I.
But it was a very good question. How does that compare? Are there people who are currently impoverished because of medical costs, and how does that compare to how the transition would be? Sounds like we're providing for transition dollars and transition ways. What do we do for people who have become bankrupt, except perhaps with them on Medicaid? Some doctors aren't accepting. All right,
Yes.
so let's get to another question, and we're getting pretty much close to the end. Are there any questions from the Facebook crowd that we need to include?
No, there were no questions on Facebook.
Okay, let me ask one more from what I'm seeing in chat. Who are the people or the organizations who are opposed to Medicare for All, and what should we know?
Okay, thank you. The opposite for Medicare for All, it's going to be the insurance companies. It's going to be the insurance companies like you never saw ever before. They are, so that's very, very clear. And that's why we need a grassroots campaign for Medicare for All, and we need to talk to legislators about it. The other issue about passing this legislation, and you can include Big Pharma in that too. When we talk about the actors that are fighting a program like this, you've got to include the big pharma. We don't talk about them as much because it's just that the health insurance industry plays into all of these factors. There's a cost to people. But the other issue regarding that is fear. So we've got to look into ourselves and say, are we ready to take this leap? Do we understand the value for ourselves, for our children, for our grandchildren, for our neighbors, to explore and to ask for, to request, to move for improved Medicare for all? That's what's at stake. The healthcare costs and the healthcare quality for all of our families and our friends. Sue, you want to add?
Yes, I think one of the things is that there's sort of the old expression, the devil you know is better than the devil you don't know. And so there's always sort of a momentum to keep things pretty much the way they are, especially for people who have insurance through their employment or others that they're fairly satisfied with. What we have to understand, when I started in nursing about 100 years ago, most of the organizations were nonprofit. They were run by religious organizations, those sorts of things. What we have to understand, hospitals, physician practices, long-term care, home care, all these elements, and pharmaceuticals as well, are for-profit organizations now, the vast majority. And so there is a lot of stake to be held in all the organizations providing healthcare now. And so there is a lot of way to go. But Jackie's point, then in caring for each other and thinking about how this would go forward to help so many more people, is a driving force. And it would bring predictability into our healthcare system. Right now, if you get sick, you're sort of not sure. And there are all these surprise billers and bills who, you know, you may be in your network, but somebody you encounter is not, and you end up with these surprise bills. So there is a lot of opposition there compared to the benefits that everybody's been talking about.
Here's an interesting, not that they haven't all been interesting. All the questions are really helpful in fleshing this out. But here's another interesting one. What is the appetite in the US for a progressive tax on income and also a national sales tax to pay for healthcare? That's the UK model. The Canadian system is paid by income tax plus probably an employer contribution. It's a radical change. What is the legislation looking at the moment?
The legislation at the moment, well, first, let me back up one thing. This question raises a very good point, which is that what is the single payer health plan in the United States going to look like? And it's going to incorporate the values of the United States, the values of our American values. So when you look at and say, well, what about the German system? They are this, the Japanese, the Taiwanese, all of those plans reflect the values of those countries, and our plan will reflect the values of Americans. Now, having spoken to that issue, I don't know. I will say right off, I do not know what the research is about the appetite of Americans for a progressive tax. So I have to pass on that one. I can say that in the legislation that is being looked at, you're talking about a healthcare tax like Medicare. Now, remember, we all now, if you're employed, are contributing to Social Security and Medicare. Not something new. This is American. This is something that we do because we feel it is important to put aside some money for our health care, especially in future years when we might not be having income coming in. All right, so now there is that issue of the, or that is, there's that the health care tax. Now, that would be less than, and I will repeat it, that will be less than, for almost all Americans, less than the amount that they now pay in insurance premiums, co-pays, deductibles, and other out-of-pocket costs. We're not talking about increasing costs. In addition, for major employers, yes, they will make a contribution, just as they now make a contribution to Medicare. Again, folks, it's not new. It's something that it is familiar. And that for most employers in the United States, it will be less. I'll throw out two business names that are tied and you might recognize who support single payer. If you're familiar with the conglomerate Berkshire Hathaway, which often is in the news because of the two chairmen, Mr. Warren Buffett and Mr. Charlie Munger. Mr. Warren Buffett calls the health insurance industry of the United States as the tapeworm of American businesses. Mr. Charlie Munger says, of course we should have single payer. It's a no-brainer. These are the two of, shall we call it, the biggest capitalists in the United States. Businesses are supporting a single payer approach. And again, it's because of competitiveness. Our products, the automobiles, the machinery, even the drugs that we use, all have considerable health care costs built into them, which are not necessary. And it makes our American enterprises less competitive. I hope I've lost track of the question. Joan, am I anywhere near?
I think you're okay, Jackie. I think
Thank you.
In a circuitous route, you got there.
Thank you.
We're just about out of time. Is there anything that the three of you would like to say as you wrap up?
Yes, I would like to say physicians are more and more behind this plan. And that might be an interesting commentary on the question that was posed about the doctors who are not taking Medicare and Medicaid. If you look at Physicians for a National Health Program, you will find a whole list of the physicians which are supporting this plan. The 159,000 members of the American College of Physicians, the 3,300 members of the Society of the General Internal Medicine, the American Medical Student Association, the American medical students, they want single payer. They've been behind this for decades. And although this seems like a weak endorsement, the most amazing thing is that the American, which fought Medicare tooth and nail, has finally recognized that they are getting out of the partnership with the American Partnership for American Healthcare Future. Now, the Partnership for the American Healthcare Future, for those of you who don't know, is an insurance industry-driven PAC. And finally, the doctors of the American Medical Association have finally made it clear to their membership, that's a very significant step. So I would like to add that. And Sue and Kate, my wonderful, wonderful colleagues in this endeavor. Would you like to add?
How about you, Kate?
One thing I would add, offsetting the costs of what we have now. I have seen people, and I did research on this, the out-of-pocket costs that people paid were so unexpected and so much more that many of those would be taken care of by a Medicare for All program. It was astounding to me, but I was a little, I have to say, curious and wondering and maybe even a bit skeptical when I started studying this, because I've been in healthcare for decades and worked in other countries. I am convinced I am convinced.
Thank you. Sue
I
Smith,
would just like to say thank you all for coming. This is a very important topic for our United States health and well-being, as well as our competitiveness, and keep track of the league activities going forward. Thank you.
I want to read someone's comment before we go to our closing. And it has several thumbs up attached to it. Until we begin to think as we rather than I, the advertising industry will direct individuals to continue to think, what does that mean to me? Rather than what it means to the country, to our economic state, and to our less fortunate neighbors. That's a very nice commentary. So with all of that, if we have not gotten to your questions, we will and will send out the answers. Thank you again for joining us for another informative Lunch and Learn. If you aren't a member of the League, I hope you'll consider joining us to add the strength of your volunteer knowledge and service. You can do that at www.lwvanarbor.org. And please join us next month as we welcome Joshua A. Douglas, author of Vote for US, How to Take Back Our Elections and Change the Future of Voting. He'll discuss some of the key points in his book, among them, how voting can be as easy as food shopping. The book's engaging and informative, and I highly recommend it. Look for your invitation and join us on the fourth Friday of April at noon. Look too for an invitation to the Ann Arbor League's Town Hall on the Michigan Independent Citizens Redistricting Commission. We'll talk about redistricting and how communities of interest can play a role in drawing the maps that will define our congressional and legislative districts. We'll host that live on April 19th at 7 p.m. So watch for your invitation. If you're watching us from outside of Washtenaw County, you can find your local league's website at www.lwvmi.org, because many of the local leagues will be hosting town halls as well. We hope to see you next time. And until then, get your COVID shots and stay well. Thank you.
Thank you, Joan.
Thank you. Thank you all. Thank you, Joan. Thank you all.
Thank you.
Good.